one more paper. I'm going to talk about modified Thompson quadricepsplasty. As an introduction, you know that the lack of knee flexion is an increasingly recognized complication of femoral and knee fractures. It's a big challenge for both patient and surgeon. Extension contracture of the knee is much less frequent than flexion contracture, but a more disabling problem, especially in Eastern countries, that we have some religious and habits that we have to do kneeling. Question of our investigation was, does earlier surgical intervention result in better final range of motion? The second question was, does flexion arc of motion before quadricepsplasty influence final achieved flexion arc of motion? And the third question was, does patient's age influence the post-operative flexion arc of motion? We have done modified quadricepsplasty. We modified the technique that we did not excise the vastus intermedius. Just we released the vastus intermedius from the rectus and lateral and medial vastuses. Our series was 40 patients and 40 knees. They were 36 men and 4 women. Most of our patients were men, because most of our trauma patients are men, and they are vehicle and bicycle accidents. Our inclusion criteria were failure of a non-operative regimen for a period of 8 to 18 weeks, and a patient that did not get improved after manipulation under anesthesia. But our exclusion were infection, hip and ankle deformity, or a neurovascular problem of the limb. We measured our patient according to Judith classification. As you know, we don't have an instrument for assessment of Thompson quadricepsplasty. That's why we use Judith classification. So in Judith classification, you have excellent result when you get more than 100 degrees of flexion arc, and you have a good result when you have less than 100 and more than 80 degrees, and fair when you have more than 50 degrees and less than 80 degrees, and poor result you have when you get less than 50 degrees of flexion arc. Our patients were 14 knees, and in 40 patients, we operated patient on average of 6.9 months after surgery, in a range from 4 to 24 months after initial trauma surgery. And we followed our patient averagely 17 months after quadricepsplasty. So we range our follow-up from 12 to 24 months after quadricepsplasty. Regarding to Judith criteria, we had 22% of excellent result and 67% of good result, and less percent of patient in fair or poor result, about 10%. This graph shows our result. Most of our patients are in good and excellent result. Our complication included 2 cases of superficial infection and 1 case of patellar fracture. Final average flexion arc improvement was 65 degrees averagely, and we had extension lag as well, but we could not improve patient that had extension lag before quadricepsplasty. From interval time of last trauma surgery to quadricepsplasty, when we view the series from this point of view, patient who has done surgery, quadricepsplasty surgery, before 6 months after the last trauma surgery achieved averagely 74 degrees of flexion, and patient in whom quadricepsplasty was done after 6 months of surgery, after 6 months of primary trauma surgery, they had 47 degrees of flexion arc. That we had a significant difference between these 2 groups. It means that when we start quadricepsplasty before 6 months, we would have better results. In conclusion, the definitive flexion gain did not correlate with patient age, so it's not important the patient age. Patient is young or older, but it was directly correlated with interval between quadricepsplasty and primary trauma surgery and preoperative flexion arc. Thank you very much.